So guys, now let's talk about the deep cervical fascia or the deep fascia of the neck. Deep cervical fascia, which is in previous texts, they used to call it the fascia coli also. The coli, the word is for the neck. So deep cervical fascia. Uh, Deep fascia of the neck is not a simple fascia that like the other deep fascias that we have in the other part of body. If you look at the fascia lata of the thigh, that deep fascia of thigh is covering the entire thigh all around, giving off some septum, and that's it. It's pretty simple fascia if you think about the thigh. Like we have a scarpus fascia in the abdominal wall. So these are relatively simpler fascia when you compare it with the neck. Well, it all has to do with the development also. There are so many things developing in the neck from the different sources, from phalangeal arches, from neural crest cells, they invaginating, evaginating, going out, coming in. So this cervical fascia also have to modify. So deep cervical fascia, it's all about its modification. So there are many modifications we have, like investing layer. Then we have some covering the gland, which is like we have a pretracheal layer, some covering the prevertebral muscle, that is a prevertebral layer, some covering blood vessels called as carotid sheath. So many extensions of deep cervical fascia are there. And it is imperative to understand the deep cervical fascia before we go any further in head and neck, because now knowing the cranial nerves, once you know the deep cervical fascia and the blood vessels, then we'll be in a very, very good position to talk about of the triangles of the neck in detail and understand them rather than mugging them up. So before we start this topic, the deep cervical fascia, now do you know any part of the body where deep fascia is not present? We usually have deep fascia everywhere, but there are certain places where deep fascia is not present. One is face. You cannot have deep fascia on the face. Muscles of facial expression, they originate from bone, but they ultimately insert on the skin, and that's how their wrinkling can cause the different type of facial expression. If there's a deep fascia on the face, you can never have a facial expression. You will have a mask face. That's why there is no deep fascia on the face, although exception is parotid gland. On the face, obviously parotid gland is considered to be on face only, but parotid gland is having a deep fascia around it. You know, the bumps are extremely painful because it is an unyielding type of fascia we have around parotid. Rest of the face, devoid. Anterior abdominal wall is having two layers of superficial fascia called as a Camper's fascia and Scarpa's fascia. Both are superficial. So again, there is no deep fascia on the anterior abdominal wall. And again, makes sense. Anterior abdominal wall need to expand. Pregnancy, obesity, ascites. So they need an expansion of the anterior abdominal wall. And it cannot be done. It can be done because there is no deep fascia. So let me write those 2 points first, that areas devoid of deep fascia. Areas which are devoid of deep fascia face except parotid region. Face except parotid region. Parotid gland is having a very thick fascia. We call it parotidomesenteric fascia because it is on the masseter muscle. So we call it parotidomesenteric fascia. There's a very strong fascia around the parotid gland. And the second is the anterior abdominal wall. Anterior abdominal wall. Posterior abdominal wall is having a fascia called as thoracolumbar fascia. Anterior abdominal wall is not having it. Now, as we said, the thing in the deep fascia are the modifications. So let's talk about the modifications of DCF. I'm writing DCF for deep cervical fascia. Let's name them first and then we'll discuss them diagrammatically one by one. The modification of the deep cervical fascia includes, number one, investing layer. There's an investing layer of deep cervical fascia. As the name suggests, investing layer will be the one which is investing certain structure inside, some glands, some muscles, some spaces. So they basically surround or invest structures inside. So we call it investing layer. Then we got pretracheal layer. Pretracheal, again, it is present in front of the trachea. Pretracheal layer is mainly enclosing the thyroid gland, although we have a muscular part of pretracheal layer, we'll discuss that, which is enclosing the strap muscle also. But the major part of pretracheal layer is enclosing thyroid gland. It is in front of the trachea. Then we have prevertebral layer. Prevertebral layer, again, tells you it is like enclosing the prevertebral muscle. The name sometimes could be misleading because when you look at the name prevertebral, we think of it is present only in front of vertebrae. No, it's not. It is present all around the vertebrae. So it is enclosing the prevertebral muscles all around. So that's a prevertebral layer. We got carotid sheath. Carotid sheath is basically contributed by the other layers only. Like investing layer, pretracheal layer, and prevertebral layer. These are the primary modifications we have. And these together will give rise to the carotid sheath. So in a way, carotid sheath is a modification of modification. It is derived from the investing layer, pretracheal layer, prevertebral layer. We will see that. Then we got a fascia called as buccopharyngeal fascia. And the one is pharyngo-basilar fascia. Buccopharyngeal and pharyngo-basilar fascia. So before we start in detail about all these fascias, look at the name, guys. Buccopharyngeal and pharyngo-basilar. The name should tell you everything about them. Bucco and pharyngeal. There are two components here. Bucco word is for buccal. Buccal means cheek. And pharyngeal obviously is for pharynx. So a fascia which is covering the cheek as well as pharynx. So there is a fascia which is covering the buccinator muscle from outside, and the same fascia goes behind and covers the pharyngeal muscle also. That is constrictor muscle. So you will see a continuous fascia outside the buccinator muscle, and the same fascia continues backward and covers the superior constrictor muscle also. And that's why the name is what? Good. Pharyngo-basilar fascia, on the other hand, is the fascia which is covering the pharyngeal wall from inside. The name says the pharyngo, so it's covering the pharyngeal wall from inside. And then this fascia goes and attached to the base of the skull. And that's why the name is a pharyngo-basilar fascia. So the one which is outside the pharyngeal wall and covering the buccinator, we call it buccopharyngeal. Buccinator as well as pharyngeal, buccopharyngeal. But the one which is covering the pharyngeal wall from inside and then it is attached to the base of the skull, that is pharyngo-basilar. So remember that buccopharyngeal is outside and pharyngo-basilar is inside. Although we will be discussing these two fascias in more detail in the pharynx part. So as of now, our main focus will be on these layers of the deep cervical fascia: investing, pretracheal, prevertebral, and carotid. To understand the deep cervical fascia modification, we got to consider it in two sections, guys. We'll take a first transverse section of the neck, and we'll see how exactly the deep cervical fascia is expanding there and what are the modifications. And then we'll see a longitudinal section. See, the purpose is entirely different. When you take a transverse section of neck, we need to see how deep cervical fascia, different part like investing, pretracheal layer, are enclosing the structures. But when we'll see a longitudinal section, our main aim there is to see the extension of the deep cervical fascia downward. Is there a fascia which is reaching till the neck only? Is there a fascia which goes to the root of the neck? Do we have any part of deep cervical fascia going beyond neck? So we got to look into that so that we can find out that if there is an infection of a particular space, to which region they can expand. Can they only go to the root of the neck, or they can even reach the mediastinum as well? So that's why, starting with that, we'll take a first transverse section and then we'll talk about the sagittal section. And both these sections have been asked in the exam in an image-based questionnaire. So first, let's take the transverse section of the neck. So when you take a transverse section of the neck, the most anterolateral muscle and the most posterolateral muscle. Now, what is the most major anterolateral muscle here is sternocleidomastoid, right? That's a sternocleidomastoid bilaterally, anterolaterally present here, and posteriorly the trapezius muscle. So there we go. Let's say this here is the sternocleidomastoid, anterolaterally placed in the transverse section, and posterolaterally we got the trapezius muscle. I'm going to show you comparative picture atlas images also once we're done with it. Sternocleidomastoid, and this one here is, I'm writing TZ for trapezius. First we said investing layer. Now this is the deep cervical fascia only, and it is investing certain structures like these muscles only. So we have an extension of the deep cervical fascia enclosing sternocleidomastoid, as you can see, and also enclosing the trapezius muscle. So that is telling me about what layer? It is telling about the investing layer. So let's say this here is the investing layer, the one which is covering these two muscles. Investing layer is not only covering the sternocleidomastoid and trapezius, there are many glands and other things also which are enclosed in it. But as of now in this section, I can only appreciate the two muscles being enclosed inside. Okay, what else? If you look onto the posterior side, let's say here's a vertebral column. Let's draw it roughly here. This is a vertebral column here. So obviously the muscle that you see in relation to the vertebral column, we call them the prevertebral muscles, like scalenus anterior, scalenus medius, and posterior. All these are prevertebral muscle. And all these muscles, they are covered with a very, very thick fascia protecting it, called as a prevertebral fascia. So the fascia that you see covering the prevertebral muscle all the way around here, this here is the prevertebral fascia. That fascia there is called as a prevertebral fascia. Now understand one thing here itself, guys. Prevertebral fascia, as I said, it is completely sleeving around the vertebral column and the muscles. And obviously inside here in the vertebral column, there is a spinal cord which is giving off spinal nerves. So if a spinal nerve has to come out from here and go into other regions like upper limb, like the nerves like C5, C6, C7, C8, they will all form brachial plexus. So when these nerves start from the spinal cord, these nerve roots start from the spinal cord, they have to leave this region and go into upper limb. And in upper limb, if you know about this, in the axilla, the brachial plexus is enclosed in a sheath called as axillary sheath, which tells me that that axillary sheath present in the axilla is an extension of this prevertebral fascia only. So when the nerves and vessels from here, when they will go out toward the upper limb, they will push this fascia along with it and forms a sleeve along with it, and that sleeve is called as a axillary sheath. So this question has also been asked, that extension of prevertebral fascia in this axillary region forms the axillary sheath. So I can say axillary sheath is one of the modification of or extension of prevertebral fascia. And what axillary sheath does? Axillary sheath encloses axillary vessels. It encloses axillary vessels and brachial plexus. Axillary vessels and brachial plexus. We'll discuss this axillary sheath content in the upper limb part and the axilla part, where we'll talk about brachial plexus. So both axillary artery and brachial plexus, they will seen enclosed in a sleeve, which is an extension of prevertebral fascia. So till now we've looked into the two modifications in the diagram. One is investing layer and one the prevertebral layer. Okay. Let's go in this diagram more further here. So obviously we expect to see the esophagus there, the pharynx and the esophagus here. And more anterior to that, there will be the trachea. So this here is the trachea. So we have a third modification there, which is present in front of the trachea, and that is called as a pretracheal layer. That is called as a pretracheal layer. This is a pretracheal layer or pretracheal fascia. Well, the purpose of pretracheal layer mainly here is to enclose the thyroid gland. The one which I'm highlighting right now, let's say this is a thyroid gland, and this is enclosed in the pretracheal layer. Well, this thyroid gland which is enclosed in the pretracheal layer is forming what type of capsule for the thyroid? Is it a true capsule or is it a false capsule? Guys, this here is the false capsule of thyroid. This is the false capsule of thyroid. See, any extension or any capsule which is coming from outside can never be a true capsule. When you look at the pelvic fascia, it forms a capsule around the prostate gland. So that pelvic fascia around the prostate gland is also contributed from the outside. So that also is a false capsule. Same story here. Pretracheal layer is contributed by the deep cervical fascia. So it is a false capsule. When you say true capsule is always the condensation of the gland's own stroma. If the stroma of the gland is forming a fascia, then you call it a true capsule. Otherwise, they are all false capsule. Doesn't matter where they are coming from. A little detail to be added here in the pretracheal layer. Pretracheal layer is actually having two parts. We have a visceral layer of pretracheal fascia and we have a muscular layer. visceral layer and muscular layer. Now, obviously, the thyroid gland, it's a viscera, we'll say here. So, thyroid gland is present in the visceral layer. So, it is enclosed in visceral layer of pretracheal fascia. This pretracheal fascia was also having the muscular layer. It is also having the muscular layer, and this muscular layer encloses strap muscles. It encloses strap muscle. So let's say if they give you an image-based question in which the strap muscles are shown in the transverse section or maybe in a longitudinal section, and you're looking at this sternothyroid, sternohyoid, or any of these midline strap muscle, and you see a fascia which is enclosing them, please don't confuse that with the investing layer. Because when you think of a fascia covering a muscle, the investing layer comes to the mind. But investing layer is enclosing the sternocleidomastoid and trapezius only. If it comes to muscle, the muscle in the midline here are enclosed in the fascia, which may look like an investing layer, but it is a part of pretracheal layer, more precisely muscular part or muscular layer of the pretracheal fascia. So we have a two part of pretracheal fascia, visceral layer enclosing the gland and muscular layer enclosing the muscles. That strap muscle it is enclosing. If I try to draw that here, like if you have a muscle in front, we have the strap muscle present in front of thyroid gland only, the sternothyroid, the sternohyoid, like that. We have muscle like these. So let me use the same color. You will have the fascia enclosing these muscles also. So that's the one I'm talking about. The strap muscle which are forming the anterolateral elevation of thyroid gland, they are enclosed in the same pretracheal fascia. So guys, by now we are looking at three major investing: pretracheal and prevertebral. And then we said carotid sheath is a modification of all the three. First, the very, very important thing is what is the location of carotid sheath? In the last 3-4 years, carotid sheath is one of the heavily asked questions. They ask the relations of carotid sheath, content of carotid sheath, theoretically as well as in the image-based questions also. So you cannot miss this part. Carotid sheath is located just posterior lateral to thyroid gland. So if I have to put a thyroid gland in here, it is posterior lateral to thyroid gland. So carotid sheath is somewhere here. Look at that. Posterior lateral. This is where carotid sheath is present. Let me just label it on one side. We'll discuss it separately. This is carotid sheath, which we already mentioned. It is an extension of investing pretracheal and prevertebral layer, and having a contribution coming from, let me draw these arrows here. One, it is coming from the pretracheal layer. We have an extension coming from the investing layer, and we also have an extension coming from the prevertebral layer. So all together are giving rise to the carotid sheath. So basically, all these three fascia give an extension, and that makes a sleeve around the blood vessels, major blood vessel of the neck. That is called as carotid sheath. Let's take out this carotid sheath from here, see it in a longitudinal section, see what are the contents in there, and then we'll talk about the relations also. So guys, let's look into the carotid sheath separately. Now let's say this is the longitudinal view of the carotid sheath. As the name suggests, carotid sheath will be having carotid vessels inside. So we have common carotid artery, and you will see common carotid artery will continue as internal carotid artery, whereas the one which will come out of the carotid sheath is the external carotid artery. So that is not the content. The vein that you will appreciate inside is the internal jugular vein. And obviously the nerve which is sandwiched in between, the nerve that you'll find in between the two is the vagus nerve. So look at carefully the highlighted part only. Those are the one which are the content of carotid sheath here. These are the contents of carotid sheath. If I name them, this here is the internal carotid artery. Internal carotid artery is considered to be the continuation of common carotid artery. I'll tell you a bit more about it. This here is external carotid artery, which is not a content. I'm just putting a cross mark on it. It is not a content. Vagus nerve, that's a vagus Vagus nerve is exactly sandwiched between the artery and the vein. You can't see the vagus nerve unless you open the carotid sheath and separate the vessels. Then only you can appreciate the vagus nerve in between. And of course, the vein here is the internal jugular vein. So these are the content: internal carotid, vagus nerve, internal jugular vein, and common carotid artery. Now, there's a very important concept here which will help you in the later part as well. If you look at there in body, there are certain blood vessels which seems to be present in a continuation. Like if you look at common carotid artery, and if you go above, it looks like the major continuation of common carotid is internal carotid, whereas external carotid looks like a branch coming out of it. And that is again developmental. I hope you heard of the term called as vasculogenesis and angiogenesis. Vasculogenesis means development of blood vessel from the pre-existing mesoderm. Now there is let's say pre-existing mesoderm is present, and if the blood vessel develops in that mesoderm, we simply call it vasculogenesis, development of a blood vessel. But when a blood vessel comes from another blood vessel, as a sprouting, as a budding, that is called as angiogenesis. Blood vessel from blood vessel is called as angiogenesis. So whenever you see the blood vessels in continuation, like common carotid artery and internal carotid artery, this tells you they are the example of vasculogenesis. So there was some mesoderm present in the pharyngeal arch or whatever, and that gives rise to these blood vessels. The proximal part form the common carotid and the distal palm form the internal carotid. But later on, external carotid bud will came out and that grow as a separate blood vessel. So that is an example of what? Angiogenesis. Why it is important to know for us? Because if you know the blood vessels in continuation, if you know the blood vessel of vasculogenesis, we can also think about that thrombus are more prone to go into which blood vessel. Now let's say from arch of aorta, if a thrombus hits into common carotid artery, once it goes into common carotid artery, it is more likely to go into which one? External or internal? Of course, internal carotid artery, because that's the continuation. Now this internal carotid artery, when it goes inside cranial cavity, what is the vasculogenesis of internal carotid? Internal carotid artery will continue as which artery? Internal carotid artery will continue as middle cerebral artery. There are other branches also, anterior cerebral and other branches, but which is a continuation of internal carotid is middle cerebral. And that's why the thrombosis are most commonly seen in the middle cerebral artery of the brain. So it's all very conceptual. You have to understand that which blood vessels are running in the same line, because they are all representing the example of vasculogenesis. You rarely will hear an example where the thrombus goes into the external carotid artery. It will not take a course of this kink and then go into external carotid. So coming to this was about the content of carotid sheath. Now the relations of carotid sheath are equally important. If I take a transverse section of the carotid sheath like the one we already saw and put it that way. So let's say this, once again, I'm going back to the transverse section only. Let's say for the orientation sake, guys, this is anterior, posterior, and obviously on both sides, that's lateral only. You can consider any of these carotids. That's why I'm writing lateral on both the sides. You can consider right or left, whichever it is. Anterior and posterior is important for us here. So inside we have obviously the common carotid and internal carotid. The vein is the internal jugular vein, and the nerve in between the two is vagus. We don't have to write them again. We already know the content inside. Now come to the relation. Anterior relation of carotid sheath, very, very important, and that is even adherent to the anterior wall, is ansa cervicalis. Ansa cervicalis. We have two descendants. One is descendants cervicalis, one is descendants hypoglossi. So both the descendants are present in the anterior relation. So that's a very, very important anterior relation of ansa cervicalis. And please remember, it is adherent to the anterior wall. It's not only related, it is adherent to the anterior wall of the carotid sheath. Whereas posterior relation, not adherent this time, the posterior relation of the carotid sheath is the sympathetic chain. That's not adherent, but yeah, it is definitely closely related to it. That is sympathetic chain, which is in posterior relation. Trust me, all these little details are the basic foundation to identify the structure, especially in the image-based question. Doesn't matter it's a cadaveric image or it's a schematic line diagram, but if you have this theoretical knowledge fixed in your brain, then it's very easy to decipher the structures. You can always eliminate the options, if not find out the right answer at one go. So the anterior relation of the carotid sheath is ansa cervicalis. The descendants cervicalis and descendants hypoglossi both are adherent to the anterior wall. So as I said, they are not just related to it, they're adherent. Posterior relation, sympathetic chain. Not adherent, it is present posterior to the carotid sheath, but yeah, it is anterior to some fascia that is called as a prevertebral fascia. We'll see that. Now we got to take this picture of the carotid sheath and put it back into the same diagram that we discussed, the transverse section of the neck. And we need to find out some more relations there so that it is easy for us to identify, especially the nerves in that region here. There was a question asked in like a couple of years back in the AIMS in which the vagus nerve was to be identified. Probably that was the first time they asked that kind of question, so it was a simpler nerve to identify. It's not difficult to find out the carotid sheath in any transverse section, and the only nerve that you see in the carotid sheath is a vagus nerve. But this is also for sure that next time when they ask this question, they're not going to ask the vagus nerve again, because that's very simple and they've already asked this question. So they might ask you the ansa, sympathetic chain, phrenic nerve, brachial plexus, where all these nerves, recurrent laryngeal nerve, where they are present. So it's our responsibility now to understand other location of other nerves also, so that if the same section is given, we could do that. Okay, so what I'm going to do is, guys, I'm going to take the posterior part of the transverse section again and put the carotid sheath along with it. So we're just focusing on the posterior part of the transverse section where we have this vertebral column. So there we go. This here is the, just make sure draw it slightly bigger this time. Here is the prevertebral fascia. It's covering all around. I'm just drawing it in this way. This is a prevertebral fascia. And let's say this here is the carotid sheath. Let's look at on one side only. This is the carotid sheath. The transverse process of the cervical vertebrae, they are known for the attachment of the scalene muscles, scalenus anterior, scalenus medius, and scalenus posterior. And again, it's not difficult to identify these muscles because they are all having a relation to the transverse process. So if you see muscle anterior to transverse process, scalenus anterior, behind scalenus posterior, and to the tip and goes outside, that is scalenus medius. So the three scalene muscle which you will see in here is the scalenus anterior, let's say in this manner. We've got a scalenus medius here, and this is the scalenus posterior. We got scalenus anterior, that's a scalenus medius, and that's posterior. Okay, so we got to look at some important relations based on these muscle and fascia. The one we already know is the vagus nerve inside, that's the vagus. One adherent to the anterior wall, that is ansa. The one which is behind the carotid sheath. Now look at this. It's behind the carotid sheath, but in front of the prevertebral fascia. That's very important to note. It is behind the carotid sheath, but in front of prevertebral fascia. This was sympathetic chain. This is sympathetic chain. And if this question is asked again, let's say in future, like I put my money on the phrenic nerve. Phrenic nerve is a very important nerve to be identified in the transverse section of the neck, in the transverse section of the thorax, in the longitudinal section, or even from the front view. So I've seen the questions being asked in the thorax part, and there was one question, image-based question given at the root of the neck, where the phrenic nerve was also to be identified. In a very recently conducted INICT, they even asked this question about the nerve responsible for the paradoxical breathing, in which phrenic nerve was to be identified again in the section of the neck. So they are very particular about asking the location of phrenic nerve, identification of phrenic nerve. If it is a transverse section, where will you find phrenic nerve? It is present in front of scalenus anterior, but importantly, behind prevertebral fascia. Please note that. It's in front of scalenus anterior. It runs in front of the scalenus anterior only. That's the main thing about its course. But yeah, it is hidden behind the
pre-vertebral fascia. So that's where the phrenic nerve is. That's where the phrenic nerve is located. It's in front of scalenus anterior, behind pre-vertebral fascia. Between scalenus anterior and scalenus medius, what do you expect to see between scalenus anterior and medius? The entire brachial plexus. Brachial plexus, when it leaves the neck region and goes into the axilla, it obviously goes between the scalenus anterior and medius only. Even the subclavian vessels goes the same way. So the nerve we are talking about here, these are the roots which are going to form brachial plexus. You can simply say cervical nerves, C5, C6, C7, or in simpler term, you can say brachial plexus roots are the one which are coming out between scalenus anterior and medius. So guys, as of now, we see one about the nerves you're talking about. Ansa is in front, vagus is inside the carotid sheath, sympathetic chain is behind but in front of prevertebral fascia. Phrenic nerve is in front of scalenus anterior, behind prevertebral fascia. And then we have brachial plexus root which are present between scalenus anterior and medius. Lastly, let's add on one more thing here. If I have to expand the same diagram again, this was trachea and esophagus. That is a trachea here. Trachea and esophagus. In the tracheoesophageal groove here, let me draw on both the side. In tracheoesophageal groove, the nerve that you'll appreciate here is the recurrent laryngeal nerve. The branch of vagus nerve is in the carotid sheath, but not the recurrent laryngeal nerve. Recurrent laryngeal nerve is running back into the tracheoesophageal groove. So this is how overall you are able to identify the structures in the transverse section of the neck. Let me show you one picture from the atlas, and we'll try to identify as many structures as possible there in it. So there we go. This is the transverse section of the neck. More or less the same kind of section that we drew, and let's identify the major fascias in it. Now first we said when we take a transverse section, the anterolateral and the posterolateral muscle. This here obviously is the sternocleidomastoid. You can see bilaterally this is the sternocleidomastoid. And here we got the trapezius muscle. Sternocleido and trapezius. And can you see the red colored fascia which is covering them? Of course, that is the investing layer. That is the investing layer of deep cervical fascia covering the sternocleidomastoid and trapezius. Clearly, this is a thyroid gland. There's a thyroid gland, and the fascia that you see around the thyroid gland is in front of the trachea. That's why it is a pretracheal fascia. That's a pretracheal fascia. And I hope you can even appreciate there are some muscles present in front. Look at the strap muscles present in front here. The sternohyoid and sternothyroid is there in front of it, and they are also covered with the fascia here. And I told you, do not confuse this with an extension of investing layer, because they are extension of pretracheal only. They are extension of pretracheal fascia only. We call them muscular part of pretracheal fascia. This is the vascular layer, the blue one, and these are the muscular layer of pretracheal. If you look at the orange colored fascia which is shown here, that is covering all these prevertebral muscles. So that obviously is a prevertebral. That's a prevertebral fascia. This, of course, is the carotid sheath. That's a carotid sheath, which is contributed by all the investing pretracheal, prevertebral. And now let's identify the nerves in there. Now starting from the anterior part, can you see the nerve present in the tracheoesophageal groove here? This nerve here is the recurrent laryngeal nerve. You can see it bilaterally present, that recurrent laryngeal nerve in the tracheoesophageal groove, the recurrent laryngeal nerve. Inside the carotid sheath, we got vagus nerve. This here is sympathetic chain. Now let me just mark it on the other side here. This is the sympathetic chain. Now, point to be noted here in the sympathetic chain is that it is present behind the carotid sheath, but in front of this orange colored fascia. So that is in front. That's how when you see a real-time section or atlas image, that the nerves are very, very close to each other. So you have to identify based on the placement inside or outside the fascia. And if I enlarge this picture further for you, can you appreciate the scalene muscles? Now this is the scalenus anterior, this here is scalenus medius, and then we have scalenus posterior behind. Now scalenus anterior and median. In front of scalenus anterior, this is what? This here is the phrenic nerve. This is the phrenic nerve. You can see it is behind the fascia. Between scalenus anterior and medius, what is that? That is the brachial plexus. These are the cervical rootlets which are going to give rise to the brachial plexus. You find it between the muscle here. Well, two important thing that you need to understand here, guys. When you see vagus nerve and phrenic nerve in the neck region, which one is anterior? Now, you clearly see vagus nerve is in front and phrenic is behind. All the very close, they are like not far away from each other. But yeah, still in front is what? Vagus, and behind we have phrenic nerve. But as soon as we cross this level here, the inlet of the thorax, the relation changes. The phrenic nerve will come in front and vagus nerve will go behind. And see, this will make sense. Why? Because the phrenic nerve is the one which will go down and supply the fibrous pericardium and diaphragm. So it is present more anterior. It is running in front of the root of the lung, in front of the hilum of the lung. Vagus nerve has to run along with the esophagus and will go downward, reach the stomach to form the gastric nerves over there. So the vagus nerve has to go into posterior mediastinum. So this relation phrenic, the vagus in front and phrenic behind in the neck, by the time they reach the thorax, as soon as they enter the thorax, the relation changes here. The phrenic nerve is the one which goes in front and the vagus nerve will come behind. So they will change their course. So when you see a transverse section of neck and when you see a transverse section of thorax, remember that the relation will be exactly opposite. In the thorax, phrenic will be in front and vagus is behind. Let me ask you one question here. If you're paying attention to this picture, guys, there is something missing here. We are not able to appreciate the ansa cervicalis. Now, why can't we see ansa cervicalis in this? There should be. Now, there should be ansa cervicalis present in front of the carotid sheath, but there is no ansa cervicalis shown here. The reason is, and the reason can be understood by looking at this vertebrae. If you look at this vertebrae, it doesn't look like a cervical vertebrae. It looks like more like a thoracic vertebrae. Reason, it is the last cervical vertebrae. It's a C7 vertebrae. And C7, the seventh cervical vertebrae, it's more like a thoracic vertebrae. So by looking at this cervical vertebra, I make out this section is from the very, very lower part of the, the neck. And carotid sheath is not reaching that level here. Carotid sheath is reaching hardly till C5 level. And this section is taken at the C7 level. So when you take a section at the C7 level, the ansa cervicalis is finished above only. Ansa cervicalis finishes somewhere here and the section is taken below it. And that is the reason we are not able to identify the ansa. If you take this section like 2 or 3 segment above, you definitely will see the carotid sheath having a relation of ansa in front. Okay, the other spaces and fascias to be discussed here in between, we first need to understand them in a sagittal section. So the next section we are going to discuss, and we have to discuss in 2 parts, guys. Please understand this. If imagine I take a sagittal section exactly like this. If I take a mid-sagittal section from here, now what all we expect to see here? If it is a mid-sagittal section, what all we'll expect to see here? First, you'll see some bony landmarks here. Like what you'll see the mandible, then you will see the hyoid bone, and then you will see below here the manubrium part. The problem with this sagittal section is, and I want you to understand this very well, because when people draw the sagittal section, they still don't get oriented. When you draw a sagittal section here, I don't want to look in front because I'm missing my submandibular gland. If I turn my head to one side, now look at this. If I turn my head to one side and then I take a sagittal section, now this section is of more use because now I have all the glands lined in one straight line. I have my parotid gland above, I got my submandibular gland below, I have my thyroid gland just below that here. So 1, 2, 3. All the major glands, they come into one straight line only. So that is an advantage of taking a sagittal section, but with the head turned to one side. So I turn my head to one side and then take a sagittal section. I can see all these glands in one line, and this will give you more information about that sagittal section. So there we go. So this time we are taking a sagittal section. And no harm in writing, we are taking sagittal section with head turned to side. Because in maximum textbook of anatomy, they will show you the sagittal section like this only, without turning the head to the side. So they miss the parotid and submandibular, especially the submandibular gland, which is important, is not to be missed. Okay. Now the diagram is going to be very schematic, so this may not give you the appearance of the real-time diagram unless I show you in the atlas image. So I want you to anticipate what you're going to see, guys. Let me turn the head to other side, and if I take a sagittal section, the first thing I'm going to appreciate here is this body of mandible. I'll see the body and the ramus part of mandible. Just below that, the hyoid bone, talking about the bony prominences, the hyoid bone, and below that here I'll find the sternum. Right? That's the first thing I'll notice. And between all these bony prominence, a fascia which is present outside and like covering them around is the investing layer. Investing layer is the outermost fascia. So investing layer is the one which is seen stretching between all of them. Let's start from this point. So as I said, in this section, let's say the section goes from mandible. This is the mandible bone, and let's show a mandibular tooth also. So this is mandible here. I'm just writing M for the mandible. Let's say here is the hyoid bone. It's a section going through the hyoid bone. And more inferiorly, let's say this is the sagittal view of the sternum. That is a manubrium part, basically. Here is the hyoid. And that's manubrium. Stay oriented with this. It's a sagittal section, so you have to presume you're seeing it from the side. You take a section, cut a section like this, and then you see it from the side here, of course. So you will see a piece of mandible, you will see a cut section of the hyoid, and you will see a piece of the manubrium from the side view. Fascia which is stretching, guys. Look at this fascia which is stretching between the mandible and the hyoid bone. It is splitting between the mandible and the hyoid bone like this. It again unites and stretches below the hyoid bone. And it again splits above the manubrium. The fascia which shows this characteristic of splitting mainly is in the investing layer. This here is the investing layer once again. Try to label it on the side I'm doing it. We need to use the space on the other side. So that's the investing layer. In the transverse section, we saw investing layer was enclosing the sternocleidomastoid and trapezius. Now what will it enclose here? Between the mandible and hyoid. Now think about it, guys. If I turn my head to this side and if you look at between the mandible and hyoid bone, what is the gland here? The submandibular gland. What is the gland above here? The parotid gland. So we're not showing the parotid region, that is higher, but at least submandibular gland can be appreciated. So we have a submandibular gland which is enclosed in between. That's the submandibular gland enclosed in the investing layer. And you can also see above the manubrium, it is enclosing a space here. So there's a space which is present here, like above the manubrium in this region. That space, which is again enclosed by the investing layer, is called as a suprasternal space, or you can even call it the burned space. Let me write the simpler term, that is suprasternal. This is called as a suprasternal space. So that's first thing you noticed in the sagittal section, that gland enclosed in the investing layer and the space that is suprasternal. Let's go further, guys. Let's remove all these things and see what is next to it. If I just get rid of this mandible, hyoid bone, and this sternum, the next thing that I'm going to see is the next fascia, that is a pretracheal fascia. The origin of pretracheal fascia above is again from the hyoid bone only. Investing layer is starting even further high. The pretracheal layer is going to start from the hyoid bone. As we know, it is enclosing the thyroid gland and muscles also. Let's only focus to thyroid gland. And then it extends downward, guys. Look at this. It is going till the manubriosternal junction. It's not ending at the upper border of manubrium like this one. It is going beyond the manubrium. It is going to the junction of manubrium and body called as sternal angle, which is at the T4 level. So yes, what is that? What fascia? That is a pretracheal fascia. That is a pretracheal fascia. What it does, it encloses the gland. This time what gland is that? That is a thyroid gland. It is enclosing thyroid gland. And then you can see it is extending downward to the manubriosternal junction or till the level of T4. Now, if it goes till the level of T4, lower border of T4, which is also the sternal angle level, you can say, how it is ending? It is ending by merging with the apex of fibrous pericardium. It is merging with the apex of fibrous pericardium. So, fibrous pericardium apex goes till this point only. So, it merges with the apex of the fibrous pericardium. See, this is the main motive here in this section, to see that from where to where they extend in the longitudinal section. Investing layer, it starts above, of course, because investing layer is enclosing the parotid gland also. We'll see that. So it's coming all the way from here, from the zygomatic arch, I can say. And then it encloses the parotid gland. Then the one you can appreciate here is submandibular gland. Then goes and encloses the space there. And that's it. Pretracheal fascia is not starting that high. Pretracheal fascia is starting at the level of hyoid only, but it goes further down. It is not ending at the sternal upper border. It is going beyond it. It goes to the manibrio-sternal angle till the level of lower border of T4, also called a sternal angle level, and merges with the apex of fibrous pericardium. Right? Okay. Now, in this section, guys, this is a huge section. I mean, we still have many things present behind. We have a trachea behind this, then we have pharynx behind it, then we have vertebral column, there is a prevertebral fascia. If I try to draw everything in one diagram only, this will just get confusing only. So that's why I've divided this diagram in two parts. Right now, you're looking at this anterior part. Now, whatever is just posterior to it, imagine whatever is there just posterior to it, we're going to draw it separately. So there we have what pharynx is behind, vertebral column is behind, and then we have some fascias covering them. So the posterior part of this diagram, we're going to draw it separately. So it's just the posterior part of the same sagittal section. So again, it will be better for your later understanding. Just you note it down that it's the posterior part of the sagittal section. The same sagittal section that we drew, it is just the posterior part, the posterior half of it. Okay. So there we go. Let's say this here is the base of skull. This is the base of skull here, right? That's the base of skull. Let's presume here is the vertebral column. So you got C1, C2, count these vertebrae there. C3, C4, 5, 6 and 7. And then I need this diagram till T3, T1, T2 and T3. So make sure if you're drawing it with me, just take it to the T1, T2 and T3. I'm purposefully leaving more gap in there. Let's say this is the pharyngeal wall. So let's say this is the pharynx or the pharyngeal wall. It's a pharynx and esophagus we are looking at, right? So we mainly have to focus in the space between the pharynx and this vertebral column. What we already discussed, guys, when he said that there are fascias covering the pharynx from inside and outside. Now, I hope you remember we said buccopharyngeal fascia was outside and pharyngobasilar was inside. Buccopharyngeal is covering the buccinator and pharyngeal wall from outside. So the fascia that you see, which is present outside here, outside this pharyngeal wall, this is the buccopharyngeal fascia. Adherent, but it is outside. Adherent, but outside. So this fascia here is the buccopharyngeal fascia. The fascia in front of the vertebral column or around the vertebral column, that was a prevertebral layer or prevertebral fascia. Let me use this blue color here. This is the prevertebral fascia. And this prevertebral fascia, it keeps on going in front of the vertebral column on and on and on and on till the sacrum. So it is going all the way till the sacrum and coccygeal vertebrae. It goes all the way till the sacrum and coccygeal vertebrae. This is the prevertebral layer or prevertebral fascia. But guys, here is the catch. It goes till the this prevertebral fascia is extended all the way to the the sacrum and coccygeal vertebrae. And yes, there is a space behind it also. You can clearly see there's a space there. That space will be called as a pretracheal space, prevertebral space. It is behind the prevertebral fascia, so we call it prevertebral space. So we have this prevertebral space extending downward, and it goes all the way till the sacrum and coccyx. But the point is, this prevertebral space of the cervical region is separated from the prevertebral space of the thoracic region. Reason, the prevertebral fascia, it gives off some extension which attaches to the anterior longitudinal ligament of T1, T2 as well as T3. Many basic books says that fascia extends till T4. Well, that's not right. It is extending all the way down till the coccygeal vertebrae. But yes, the prevertebral space above and the prevertebral space below are separated from each other. Why? Because we have extension of this fascia which comes back and attaches to the anterior longitudinal ligament of T1, T2, and T3. Obviously, the body of vertebrae is having an anterior longitudinal ligament here, and that anterior longitudinal ligament is receiving the attachment from prevertebral fascia, which is separating this space from it. So this space here is what I'm writing P for it. This is a prevertebral space. So guys, the P here represents the prevertebral space. That is the prevertebral space. Okay. Now there's another fascia which usually we don't talk about. Radiologically, we don't talk about it. In the radiograph, we talk about buccopharyngeal fascia and the prevertebral fascia and the ENT also. But one fascia which is there anatomically, which is present, but it cannot see it in the radiograph, so that's why they do not mention it in the radiographs. That is called as a alar fascia. Alar fascia, which is also called as an anterior layer of prevertebral fascia. You call it alar fascia, or you can call it the anterior layer of prevertebral fascia. That's why I'm using the same color only. Anterior layer of prevertebral fascia. It starts from the base of the skull. It comes down like this, and it merges with the buccopharyngeal fascia. Look at that, guys. It merges with the buccopharyngeal fascia. This fascia here is called as the alar fascia. Alar fascia, as I said, also referred as what? Anterior layer of prevertebral. Anterior layer of prevertebral fascia. And because of this alar fascia, what happens is now you see another space there, and this space is trapped between the buccopharyngeal fascia and the alar fascia. Look at this. This space is trapped between the buccopharyngeal and alar fascia. Now I'm writing R for this space because the space is called as a retropharyngeal space. It is behind the pharynx, so we call it the retropharyngeal space. That's a retropharyngeal space. Generally, we say retropharyngeal space to everything which is present behind. I mean, even they call this as a retropharyngeal space only because it is behind the pharynx. Because we are not able to appreciate this alar fascia radiologically, so the entire space they refer as a retropharyngeal space. But anatomically, the true retropharyngeal space is present between the alar fascia and buccopharyngeal fascia. They asked this question, so please remember that retropharyngeal space is between buccopharyngeal and the alar fascia. So what about this remaining space? Now, the point about the remaining spaces, if you look at the prevertebral and retropharyngeal space, fortunately, these spaces are closed below. It is by the extension, and this one is because it is fusing with the buccopharyngeal fascia. So if there is any infection present in prevertebral space or at the true retropharyngeal space, that will not go beyond certain level. That will stay in the cervical region only. But unfortunately, if there is any infection present in this space here in between, then there's nothing stopping below. It can easily go downward, and keep on going downward into the thorax and reach the posterior mediastinum also. So the abscess which started here in the cervical region, because it can use this space to go down and reach the posterior mediastinum to compress the esophagus and trachea, causing dysphagia or dyspnea, and that's why this space is called as a danger space. This space here is called as the danger space. So I'm writing D here for the danger space. Now this was the AIIMS image-based question asked in the sagittal view. So gave a sagittal section of the neck in which the danger space was to be identified, which is mainly present between, you can say it is present between the anterior and posterior layer of prevertebral fascia, or you can say between alar fascia and prevertebral fascia. And I wanted to please note it down also that infections of the danger space can easily drop down to posterior mediastinum and they can cause dysphagia and dyspnea. I repeat again, if you're writing, the infections of the danger space can easily drop down to posterior mediastinum. This will continue as posterior mediastinum only. Easily drop down to posterior mediastinum and can cause dysphagia and dyspnea. To the posterior mediastinum and can cause dysphagia and dyspnea. So this was the posterior part of the sagittal section, and that was the anterior part of the sagittal section. Now I'm going to show you a picture in which we can see all that together, an atlas image. And just so that we can have a better orientation, let's flip the section. We should be habitual of seeing the sections from both the side. especially sagittal section from both from the right and the left side, you should be able to identify it. Right now, what we're drawing is here, anterior is on that side, posterior is here. But the image I'm going to show you is other way around. So you have to think about, you have to look into the fascia and then identify it here. So there we go, guys. This was the transverse section, and there comes sagittal. Look at this. That's a face is on the other side. This side. So this time here is anterior, obviously that is posterior. Let's start from the posterior aspect itself. Look at the fascia which is present in front of the vertebral column, that the thick orange colored fascia we have here. This is the prevertebral fascia. I'm writing in short, that is PVF, that is prevertebral fascia. And you can see, if you look at the prevertebral fascia closely, it is extending all the way downward. It is going, keep on continuing downward here. It has some attachment to T1, T2, T3, which is not shown in this basic image. Look at the green colored fascia here, coming to the one which is again coming from the base of the skull. And that here is the buccopharyngeal fascia. There is a buccopharyngeal fascia. And in between the two, if you can appreciate, there's another orange colored fascia which is shown here, coming from the base of the skull. That is an anterior layer of prevertebral fascia, and that is the alar fascia. That is the alar fascia. Let me highlight the space for you. The true retropharyngeal space is the one which I'm highlighting in yellow. Look at this. It is extending between the alar fascia and buccopharyngeal fascia, and there we go. It is obliterated here. That's it. It's not going beyond this point. Whereas if you see the space behind it, that's the danger space. That's the danger space which is extending. Look at this green color here. It is extending downward. Nothing is stopping it below. It is all the way going into the posterior mediastinum. So that is the danger space, and that was the question asked. The danger space. If I enlarge this section even further, you can try to identify more fascias present anteriorly here. Look at that. Look at the red one, guys. This one, this is again an investing layer. Now, the difference in this diagram and the one when we drew it with the head turned to one side. This is simply a sagittal section in this manner. So you can see it is coming all the way from the symphysis mentae part to the hyoid bone, and then it is descending downward. So it is not, that's why submandibular gland can't be seen here, because the section is a mid-sagittal section with this, we're looking ahead, facing forward. So this is the investing layer, but at least you can see the investing layer above the manubrium is holding a space here, and that space was the suprasternal space. You go further backward, you can see another fascia coming downward here and enclosing a thyroid gland. This is a thyroid gland, and obviously this is what? This is a pretracheal fascia. And what we discussed for the pretracheal fascia, that it goes beyond thyroid gland into the mediastinum, and then it is merging with the fibrous pericardium. You can see the major blood vessel of the heart is shown here. So the fibrous pericardium is having its apex here, and it is merging with it here. That's merging with the fibrous pericardium. So these are the few things which we can notice in this sagittal section. The spaces are the more important thing to note. I mean, the prevertebral space and the retropharyngeal space and the danger space. One, if the question is asked, we said alar fascia is fusing with the buccopharyngeal fascia, but at what level? This alar fascia, the one, if I just take you back here for a second, we said the alar fascia, you saw it is merging with the buccopharyngeal fascia, right? It is merging with the buccopharyngeal fascia. I'm putting this asterisk sign here. That's point. It is merging here, right? At what level it merged? Well, it's quite variable. It can merge anywhere between C6 to T4. It can merge anywhere between C6 to T4. So you can just note that also. This alar fascia it merges with buccopharyngeal fascia between C6 and T4. So you cannot pinpoint it. That fusion can be seen anywhere between C6 to T4. In that case, you might argue that, okay, if it is going till T4, then obviously the retropharyngeal infection can also come into the mediastinum. Yes, it can, but it is still the superior mediastinum, because the posterior mediastinum starts after T4 only. The major posterior mediastinum is after T4. So it can still only go into the superior mediastinum, not the posterior. Posterior mediastinum infection, only danger space can reach there. Well, after these two sections, we need to kind of summarize everything together, and especially the investing layer, because we are doing it in the scattered form. In the transverse section, we saw investing layer is enclosing sternocleidomastoid and trapezius. We saw two things investing there. In the sagittal section, we said it is enclosing the parotid gland. We did not see though submandibular gland and the space called a suprasternal space. And similarly, there are other modifications also we have for the investing layer as well. So let's finally, in the deep cervical fascia, talk about those modifications of investing layer. So finally, the two important spaces that we have to discuss, which are enclosed by the investing layer. Guys, investing layer is present all around the neck, right? It's like a sleeve around the neck. You wear a collar around the neck, it's like a fascia over there. When we took a sagittal section, we saw a space above the manubrium. But that was because we took a sagittal section. I can only see a space above the manubrium. But if you take a section more laterally, which is going above the clavicle, we do have a space above the clavicle also. So there is space above the manubrium and there is a space above the clavicle as well. So we have a suprasternal as well as supraclavicular space. Both are separated from each other and both have their some contents inside. So if I first try to put it diagrammatically, guys, if this here is the manubrium, that's the body of the sternum. So this is manubrium here, and here we have the clavicle. Right? So looking at the manubrium and the clavicle. So this investing layer of deep cervical fascia, it encloses a space here that is above the manubrium, and it also encloses a space above the middle part of the clavicle, mainly between the middle third of the clavicle. Simply say above the clavicle. This space, the suprasternal, and this space, supraclavicle. This is called as the suprasternal space, also called as the Burns space. Suprasternal space or Burns space, whereas this one here is called as a supraclavicular space. Needless to say, if you have any space present in the neck or anywhere else, it somehow is surgically important here. Suprasternal space, the Burns space, or supraclavicular space. Now, what are the contents? Let's again anticipate the contents here before we write them simply. Suprasternal space, guys, what content will be there? You can see both the medial end of clavicle is closed, right? We have a medial end of the clavicle here. So there is a ligament which is stretching between the clavicle from clavicle to clavicle here. That is called as interclavicular ligament. So that interclavicular ligament is connecting the two medial end of the clavicle. One structure. Second structure that you'll expect to see here is the sternal head of sternocleidomastoid. If I turn my head to one side, you can see this muscle sternocleidomastoid. Now, one head of the sternocleidomastoid is originating from the clavicle, but one head is coming, look at this, from the sternum. You can see that this is the sternal head here. So that sternal head of sternocleidomastoid is another structure that you will see inside the space only. And the third content is the loop which is connecting the anterior jugular vein. We have external jugular vein, we have internal jugular vein, but we also have a vein running close to the midline of neck called as anterior jugular vein. So both the anterior jugular vein, they come in here and they have a loop which is connecting them, and that is called as a jugular venous arch, connecting the anterior jugular vein. That is also the content of suprasternal space. So if I write it here, the content of the suprasternal space goes like, number one, what was the ligament? It was the interclavicular ligament. We got interclavicular ligament. Number two, we got jugular venous arch. What is jugular venous arch? I repeat, it is the venous arch connecting what vein? Anterior. Don't write internal, external. It is connecting the anterior jugular vein. Anterior jugular vein. And number three is the sternal head. Sternal head of sternocleidomastoid. Sternal head of sternocleidomastoid, that is also there. So these are three major content of the Burns space or suprasternal space. We have some lymph nodes also there. Coming to the supraclavicular space. Now we have some very good practical importance of the supraclavicular space, guys. I have to consider it separately again. Now, for the supraclavicular space, let us say this is the clavicle. I'm just putting it separately here, and that's the space we are talking about. See, this supraclavicular space is invaded by certain structures which either have to come out or have to go in. So, like the structures over there are not to stay inside. We have structures in this space which is either coming out or going in. Now, what first of all goes in? Something which is superficially placed and then goes through the space and drain inside, that is external jugular vein. External jugular vein is running superficial to sternocleidomastoid, and that external jugular vein will come into this space, and through this spaces goes even backward and drains into subclavian vein. So one thing, that is external jugular vein, will be seen coming like this and then going into this space to drain into the subclavian vein. So one structure there is what? That is an external jugular vein. Second thing, something which is coming from inside to outside. The branches from the cervical plexus, we call them supraclavicular nerves. Supraclavicular nerves are present inside, they're present deep to the fascia here, and then they pierce the deep fascia, and through this space, those nerves come out having three branches. These are supraclavicular nerve. That's a supraclavicular. So the two contents of the space are external jugular vein and supraclavicular nerves. Now this the supraclavicular nerve is very, very important. Why? The name and the supply is not corresponding. We call them supraclavicular nerve because the origin is above the clavicle. But ultimately the branches are coming below the clavicle. So the skin which is supplied by supraclavicular nerve is below. The name is supraclavicular, but the skin supplied by the supraclavicular nerve is all below the clavicle here. We got three branches there for the supraclavicular. One is the medial branch. We got this intermediate branch. And this, of course, is the lateral branch. And out of these three branches, two are a potential question. Which two? First, intermediate branch. Now, this intermediate branch, the thing about the intermediate branch is it can be seen piercing clavicle. It may pierce clavicle when it comes down. It may pierce clavicle when it comes down. So out of the three nerves, rest two are just passing superficial to clavicle, but this intermediate branch can be seen piercing the clavicle, which at times doesn't make sense that why a nerve is piercing a bone to come down. Well, the fact is the nerve is not piercing the bone is ossifying around the nerve. We all know that clavicle is partly by the membranous ossification. So that ossification takes place around the intermediate branch of supraclavicular nerve. So finally it gives a appearance that the nerve is piercing the bone and coming out, but the fact was that bone was ossified around the nerve itself. And what is the importance of lateral branch? See, if you look at the three branches supplying here, medial branch must be supplying the skin somewhere here, intermediate somewhere here, and lateral branch is supplying the skin over the deltoid region, in this region, in the upper part of deltoid here. And why it is important, guys, this lateral branch of supraclavicular nerve is having the dermatome of C5, So it is supplying the skin in this region with the C5 dermatome. C5 also is an important root value for the phrenic nerve. Phrenic nerve supplies diaphragm. Phrenic nerve is C3, C4, C5. So phrenic nerve is also having C5. So if somebody is having a diaphragmatic pain is obviously carried by the phrenic nerve. Phrenic nerve is having C5, but C5 is also supplying the skin at the shoulder tip here. And that's why the diaphragmatic pain are referred to the shoulder tip. Because the same C5 root which is in the phrenic nerve and the same root value is also supplying the skin over this region here. That's what the referred pain is all about. So because of this lateral branch of supraclavicular nerve, having a C5 dermatome, diaphragmatic pain are referred to shoulder tip. Diaphragmatic pain are referred to the shoulder tip. I hope you all know about the referred pain. The brain is more acquainted to the pain which is coming from the somatic structure, from the outside. So we are more habitual of knowing that the pain coming from the skin or from the muscle from the outside. So if a pain is coming from an unusual region or from anywhere else, or from where generally the pain is not, the sensation are not coming from, so the brain might confuse that sensation with the sensation coming from somewhere else. So that is what you call as a referred pain. Finally, just to summarize the entire investing layer of deep cervical fascia at one place. So the investing layer of deep cervical fascia, it follows the rule of two. Guys, it follows the rule of 2. Now, what this rule of 2 says, it encloses two muscles. We know that which two muscle are we talking about? We're talking about the sternocleidomastoid and trapezius. That is the first two here. It encloses two glands. Which two gland? One is parotid gland. We said face is devoid of deep fascia except parotid region. So one is parotid gland and other one is submandibular gland. Parotid and submandibular. Then we got the third one, that is it encloses two spaces. We just discussed the two spaces. Which two spaces? We got Burns space, that is suprasternal space, and also supraclavicular space. Two spaces. It encloses two ligaments. I should not say encloses, actually it forms two ligaments, not just encloses. The better word than the encloses is it forms. It forms two. There are two ligaments which are the modification of investing layer, and those two ligaments are stylomandibular. One is the stylomandibular ligament and the other one is the sphenomandibular ligament. Stylomandibular and sphenomandibular ligament. And lastly, this also forms two pulleys. What muscles need a pulley, guys? What two muscle in the neck which require a pulley? The muscle which are having more than one belly. So we have a like anterior and posterior belly of digastric, and we have a superior and the inferior belly of omohyoid. So the two muscle which will need a pulley is a digastric muscle. And the next one would be the omohyoid muscle. The digastric and the omohyoid. So that is so-called the rule of 2 for the investing layer. Encloses two muscle, two gland, two spaces, two ligaments, and also forms two pulleys.